clinical features of ovarian cancer, but now in these clinical features I am basically focusing of epithelial origin cancer, ovarian cancer. That's why this clinical feature totally based on this epithelial origin cancer. And as I already mentioned, epithelial origins are serous, mucinous, intramoid, clear cells and the Brenner cells. So these clinical features basically depends upon this epithelial origin. Clinical features is a simple. There is most specific I am going to tell is a enlarged left supraclavicular gland. It is also called as a Warsaw gland. There is a enlarged left supraclavicular gland, I means Warsaw gland, and others is the stomach in abdominals, maybe bloatings, weight loss, anorexia, constipations, and respiratory distress also there. Respiratory distress, of course, due to the due to ascites and pleural effusions, and there is a cachexia, edema of the legs. And when we are doing the physical examination, while we are doing physical examinations, there we can find the pelvic mass. Pelvic mass is felt in hypogastrium regions. That you must need to focus this pelvic mass in hypogastrium regions, and there is tenderness also. And we will do the por vagina test. In a por vagina, there is a nodules are found. Nodules are felt in posterior fornix. So these are the main clinical features. I am not going in details, but the most important things is there is an enlarged left supraclavicular gland or Warsaw gland, and there is in abdominal symptoms like bloatings, weight loss, anorexia, constipations, feeling of abdominal distension, dyspepsia, and the loss of appetite. Okay, dull abdominal pains. These are also important. And but another is a respiratory distress. There is a respiratory distress due to ascites or pleural effusions. And in a physical examination, you need to think this: if the pelvic mass is felt in a hypogastrium regions and if tenderness there, you need to suspect about ovarian cancer. And in a por vagina, their nodules is being felt in a posterior fornix. Okay, these are the clinical features. Now let's go how diagnosis. In a diagnosis, there are okay, in a diagnosis there is, of course, we will do the transvaginal ultrasound. And in a tumor marker, I already told you this is epithelial origins, and mostly epithelial is a serous. That's why there is a CA125 is increase. Okay, and we can do the fluid is collect from abdominal paracentesis, and we can do the X-ray also to exclude the pleural effusions. We can do the barium enema to exclude the ball malignant, and of course we can do CT, ultrasound, MRI, and even PET. But what I want to describe about this tumor marker, some other tumor also have a different tumor markers. So these questions in MCQ, these questions are very important. So I just want to mention few tumor marker. Okay, the tumor marker first is if the serous epithelial, I already told you CA125 tumor marker is increased. If mucinous, in a mucinous epithelium origins, then there is a CA99 is increased. And if there is a endodermal sinus is a non-epithelial carcinoma, there is a alpha fetoprotein increase, as well as the alpha-1 antitrypsins also increase. But in endodermal sinus, there is a one histologically one is important bodies is find Chiller Duval bodies are present in microscopically if there is a endodermal sinus non-epithelium tumors is found. And these Chiller's double bodies are actually single papilla, and this one is covered by these tumor cells, and there is a central blood vessels histologically. And if there is a choriocarcinoma, of course SCG is increased. Then if there is a dysgerminoma, then there is LDH as well as the alkaline phosphatase present there in a blood. Okay, and in a granulosa cell tumor, there is a inhibin is increased. And histologically there is a Kohl-Exner bodies. It is a gland-like structure and filled with the acidophilic materials. This is granulosa cells. In a granulosa cells, there is inhibin increase, and histologically we can see the Kohl-Exner bodies. Okay, these are the actually for a diagnosis purposes. Different tumors has a different structure, histological structure different. If we do the incisions, and then microscopically if we see the tumor cells, microscopically also different. And the most important are that these tumor markers are very important for the diagnostic purpose. Now in the next video we will describe how we treat. Okay, now we talk about treatment of ovarian cancer. And for the treatment we need to understand about this FIGO classification. Treatment totally depend upon the FIGO classification. And according to the FIGO classification, if we found the tumor in the stage first A or B at that time, and if the patient is young, okay, if the patient is young, what we can do? We will do the unilateral salpingo-oophorectomy. Why we will do the unilateral salpingo-oophorectomy if the young patients? Then because the after childbearing we will remove again this uterus and the vagina, uterus and ovary. Okay, so but before a childbearing stage we will do the unilateral salpingo-oophorectomy, and after childbearing, after she got child, then we will remove uterus as well as the ovary. But if the patient is a elderly patients or elderly woman, then we will do the direct hysterectomy plus bilateral salpingo-oophorectomy. Okay, if the elderly patient, we will do hysterectomy plus bilateral salpingo-oophorectomy. But this is the stage if the stage first and second. So for example, now is a stage second plus first C. Second means pelvic extension. Okay, at that time what we will do? We will do the surgery, same hysterectomy and bilateral salpingo-oophorectomy, and plus followed by 3 to 6 cycle of chemotherapy. In chemotherapy, of course, we will do the platinum origin drugs, cisplatin, carboplastins, and the taxane derivatives, paclitaxel. Okay, this is in a chemotherapy. But in a second and first C, we will do the surgery as well as followed by 3 to 6 cycle of chemotherapy. Okay, most important is now is a advanced stage. In advanced stage, if the patients in advanced stage, it means that what? Third plus fourth stage. Here we will do surgery plus we will called as debulking surgery. What is debulking surgery? Later I will describe what is debulking surgery. Debulking surgery plus 6 cycle of chemotherapy. 6 cycle of chemotherapy, especially platinum based drugs, cisplatin and carbaplastin or paclitaxel. Okay, this is the taxane derivatives. So the treatment of advanced stage, third and fourth stage, debulking surgery plus as well as 6 cycle of the chemotherapy. And in chemotherapy mostly nowadays cisplatin and carboplastin and paclitaxel, these drugs are chemotherapeutic drugs are being used. Okay, now what is debulking surgery? Debulking surgery means total it is also called as a cytoreduction reactions. Cytoreduction. Okay, cytoreduction means total removal as much as of tumor as possible during surgical procedures, and it is aimed to reduce the tumor load. Okay, and debulking surgery, how we will do? Total abdominal. Okay, total abdominal hysterectomy. Total abdominal hysterectomy plus bilateral salpingo-oophorectomy plus complete omentectomy plus resection of any metastasis tumor. Okay, this is very important. Advanced stage third and fourth, it means that this third means extension to the omentum and the small ball. Fourth is already distant metastasis. That's why what we will do, debulking surgery. As much as we can take out these tumors by surgery, it is good for the patients. And same times we will do the post-operative 6 cycles of the chemotherapy, especially cisplatin, carboplastin are being used. Debulking total abdominal hysterectomy means from the abdominal we will do the hysterectomy as well as the bilateral salpingo-oophorectomy and complete omentectomy and resection of any metastasis tumors will resect and the throat. This is called as a debulking surgery. So these are the most important treatments which are being used in ovarian cancer. Okay, that's all for the ovarian cancer. Thank you.